is Silvia Bonfanti. I'm Italian. I come from a little village from northern Italy, near a lake. Looks a bit like Geneva. I always loved sports. I've always done a little bit of everything in my life. Dance, swimming, tennis, skiing, everything, like hyperactive child, very happy to do sports. In Italy we have a big system to control athletes that are not a high-level athlete, whatever athlete. So there I met my first sports medicine doctor that I liked, and I thought, oh, that's a cool job. I went to an international school where I learned many languages, and then I always liked biology, chemistry, so I decided to do research in genetics or bio something, until my dad told me, Silvia, you like people a lot. I don't see you in an office with technical and alone. And so I thought, oh, that's true. So maybe I'll do medicine. And then my idea of the sports medicine popped up again. So then I studied medicine in Pavia, which is a beautiful university city in Italy. And then I needed a change from the system in Italy, and I felt like I needed to see the world a bit more, and I somehow randomly came here because I had a friend who came here, so I thought I'll come for a year and see. And then I'm stuck here since 15 years. That's why. That's a very good question, because very often people don't know what a sports doctor do. Let's say we take care mainly of active people. On the spectrum of active can be from somebody who's 75 and likes to walk twice a week to a professional level athlete. We take care mainly of two big branches. One is the traumatological part, so accidents. You go skiing, you have a knee sprain, to the overload pathologies, where overload pathologies can be the person who was active, then during pandemics they stopped all their normal activity, and so they just started to run, and all of a sudden they ran 3 times a week, and then they started to have knee pain or foot pain. We are specialized in conservative treatment, so we don't operate, but we have the knowledge of knowing when to refer to a surgeon, because it is a surgical treatment that is needed. 20, 30 years ago, patients were not questioning a doctor, whereas now they question what we say, because they have read on the internet about it, and they want to be sure that they have understood well. And this is also raising awareness in us that we were probably not explaining well, not explaining enough, not making sure that the patient had understood what he had. To give you an example, a lumbar MRI is a big problem, because there is no clear link of what we see on the MRI and what the patient feels. They have done very big studies with a lot of patients, completely asymptomatic patients, and done MRIs every 10 years, and saw a discal protrusion and hernia arthrosis happening, the patient still being asymptomatic. So when today the patient comes and tells you, I have an hernia, that's why I have back pain, we have to turn the story around, because that is not the truth. Clearly there is a point of the patient awareness of what he has, or our communication towards them, and we don't have a training for that. So that could be something that somebody would help us train to give this information. people read a lot because they have access to information, but sometimes they don't have the capacity to understand what is important and what is not important. You know, sometimes people come and say, I have a grade 3 chondropathy, and we know that the cartilage is not innervated, so it cannot give pain. So the patient has just spent 2 months panicking, thinking he will have a knee replacement, when in fact that's probably not the problem. And as long as technology evolves, I still see that there is an important need for us to see the patient and to touch the patient, because the diagnosis comes from the exam and not only from the MRI or the CT. So this is a problem that will come, a lot of knowledge, difficult to handle, and find a way to help the patient to understand well what he has us to explain, and so that we find the right solution.